In Module 13, we'll discuss Introduction to Immunohematology. Immunohematology is more commonly known as blood banking or transfusion medicine. Simply put, immunohematology is the study of antigen-antibody reactions. As we learned in the serology unit, antigens are structures which are recognized as foreign by our body, which causes our body to produce a specific protein called an antibody, which will attach to and result in the destruction of the offending antigen. In the blood bank, we test for the presence of antigens on red cells, and we test for the presence of antibodies in the patient's serum or plasma, which will cause heme agglutination, which is the agglutination or clumping of red blood cells. There are so many different applications for this procedure, but the bottom line is we use reagent antibodies to detect unknown antigens on the red blood cells. For example, I want to know your ABO type, so I will test your cells with known anti-A and known anti-B. And based on the agglutination reactions, I will know whether or not the A and or B antigens are present because the cells will be agglutinated. If no agglutination occurs, then those antigens are absent. We use reagent red blood cells with known antigens to detect unknown antibodies. For example, there's two parts to your blood type. There's the forward, which tests for antigens on red cells, and there's the reverse, which tests for ABO antibodies in the patient's serum or plasma. So if you forward type and the A antigens are present, then in the reverse type, we would expect a reaction with the B cells, but not with the A cells. Because in the ABO blood group system, we make naturally occurring antibodies against the A and B antigens that we lack. So a group A person would not have anti-A in their serum or plasma because that would mean they would destroy their own A cells. That's it. That's what we do all day long. Test for antigens on cells and antibodies in serum. There are two settings for the practice of immunohematology: donor centers and the transfusion service. Donor centers screen, collect, process, and distribute blood and blood components to area hospitals. They do not transfuse blood. They simply provide blood and blood products to the transfusion services. They may cross-match blood for facilities which do not have a transfusion service, or the patient is difficult to find blood for. Transfusion service, usually located in a hospital. We test the patient's blood for the type, ABO and D, presence of antibodies, and we cross-match the blood to make sure it's compatible. We also prepare components for transfusion to patients. For example, fresh frozen plasma is frozen, and prior to use, we have to thaw it out. The testing presented here is performed at both types of facilities. What are some characteristics required to work in immunohematology? The types of testing performed in immunohematology requires meticulous technique. You set your tubes up in the same order each and every time. Do not put the wrong samples in the wrong rows. Attention to detail, both in performance of your testing and recording your results. Impeccable record keeping. Do not transcribe reactions from patient A into the record of patient B. This could result in disaster. Correct interpretation and analysis of test results. Again, you are responsible for this patient's life. So if you misinterpret an antibody screen, that it was positive but you called it negative, this could result in some fatal type of reaction with the patient. Selection and distribution of compatible blood and blood components. There have been documented cases that a patient received 5 mL of ABO incompatible blood and died. And then there's some patients, and one case I am aware of, who received 2 or more units and they lived. Each patient's immune system is unique, and how they respond to these incompatible cells will vary. Failure to interpret reactions correctly may lead to a patient getting incompatible blood or blood components, resulting in tragic consequences, the most severe being death. Individuals who thrive on stress, like myself, I'm a blood bank specialist, love working in a high-level transfusion service. There's nothing like giving out 50 to 100 components in a 2 to 3 hour period and the patient lives. You are on top of the world. ABO typing is the most important test performed in the transfusion service. Patients form potent antibodies against ABO antigens they do not possess. There are structures in nature that are so similar to these blood group antigens that we're exposed to them all the time, and we maintain high levels of ABO antibodies to the ABO antigens we do not possess. There are two parts to the ABO testing. Test the patient's red cells with reagent typing sera. In this case, the antigens are unknown, so we test with anti-A and anti-B. Test the patient's serum or plasma with known A and B cells. In this case, the antibodies are unknown. So if you have a group A person, their antibodies will react with group B cells. Look for the presence or absence of red cell agglutination. This is called the forward red cell or antigen typing and reverse ABO antibody detection type. The two test results are compared and a patient's type is determined. With the exception of newborns, because they're not making antibodies yet, you must perform the forward and reverse. ABO discrepancies are not that uncommon, so you may have to do additional work to determine a patient's ABO type. I want you to know that there are 4 major ABO blood groups, A, B, AB, and O, with A and O being the most common in the United States, about 44%, 42%. In Asia, the most common blood group is O and B. So depending upon where you live in the world will determine the frequency of ABO blood groups. This picture illustrates the antigens and antibodies present in each of the 4 blood groups. Let's look at Group O RBCs. These are called the universal donor because Group O RBCs do not have A or B antigens. So they are ABO compatible with all blood groups. And we're just talking the cells. We separate the red cells from the plasma. And so you can see that by being Group O, that your cells would be compatible with all blood groups because they lack ABO antigens. So even if a patient has ABO antigens, they're not going to react with Group O cells. Group AB is the universal donor for plasma, as there are no ABO antibodies present. So let's look at Group AB. The antibodies present, there's none. That's because both antigens are present. And these are the preferred people to make plasma products, such as platelet concentrates. Universal donors are compatible with any blood group and are given in medical emergencies where the patient is bleeding out and there is no time for compatibility testing. So what I like to do is give my 2 Group O negative units out the door, and they put a patient's blood sample in my hand so that while they're infusing those units, I can determine the patient's blood group and give ABO compatible. In some parts of the world, antibodies are called agglutinogens because they agglutinate antigens. It's important that you recognize both terms. The picture to the right illustrates a simple slide test for the presence or absence of ABO antigens. So when you look at a AB blood group, which is at the top, when you add the known anti-A antibodies and the known anti-B antibodies, you see that they're agglutinated, meaning they're all clumped up, and there's clarity in the background. If you look at the group B, they are not agglutinated by anti-A because the A antigen is not present, so you see a smooth, silky appearance. When you add anti-B to a B cell, agglutination occurs, and so on. A is agglutinated by anti-A but not B, and then group O is not agglutinated by either one. They're smooth and silky. So by looking at the reaction of agglutination versus no agglutination, we can determine a patient's ABO group. Study the reactions and interpretations carefully. In every test done in the transfusion service, either the antigen or antibody will be known. It's like doing an experiment. In an experiment, we always have known variables and one unknown variable so that we can determine the absence or the identity of the unknown. Rh or D type, in addition to ABO antigens, all individuals are tested for the Rh antigen. The term Rh is a misnomer as it refers to an entire blood group system. There's D, big E, big C, little c. There's probably about 100 different Rh antigens, with D being one of them. Due to the term Rh being used for as long as I can remember, the term Rh positive and Rh negative, no matter the inappropriateness, continue to be used today, because the nursing personnel and other staff members would not understand if we started labeling the blood as D positive and D negative. The D antigen, the Rh positive means the D antigen is present. Rh negative refers to the absence of the D antigen. The D antigen is very, very immunogenic, meaning that if an Rh negative person receives Rh positive blood, the likelihood of developing an immune anti-D is greater than 80%. For that reason, everyone is tested for the D antigen and given appropriate blood. RhD positive individuals can receive Rhd negative blood as there is nothing for them to react to. Pregnant women who are Rhd negative must be given a product known as Rh immune globulin. A lot of times they'll know it by the manufacturer, Rogam, when pregnant with an Rhd positive child. RHIG is anti-D in a bottle, and it is injected into the Rhd negative mother and will attach to any D positive fetal cells which have entered her circulation, especially during the birth process. That's when the biggest fetal maternal bleed occurs, with fetal cells entering the maternal circulation. These cells that are coated with this reagent anti-D are recognized as foreign by her body and destroyed before her own immune system kicks in to form anti-D. If an Rhd negative woman develops anti-D and becomes pregnant with an Rhd positive fetus, her antibodies will cross the placenta and destroy the fetal red cells, resulting in death. And as the pregnancy progresses, the amount of anti-D grows higher and higher and higher. The first child, if this is the immunizing event, will survive, but after that, it's too late, and the antibody becomes more and more potent and pathogenic, and unless very drastic measures are taken, the fetus will die. You'll learn much more about the importance of this product, the Rh immune globulin, during the immunohematology course in the MLT program. After the ABO and D typing, the next most important test is to detect blood group antibodies in the patient which are directed against red cell antigens they do not possess. This procedure is called the antibody screen. We're going to screen the patient's serum or plasma for unexpected antibodies, and unexpected antibodies are those other than ABO. Just because you're group A and I'm group A does not mean that our blood would be compatible with each other. Pregnancy and blood transfusions expose us to red cell antigens we do not possess. In pregnancy, half of the antigens of the fetus come from dad and may be foreign to the mom. And so if she is pregnant with a fetus that has antigens she does not possess, she may react and make immune antibodies. Donor blood comes from individuals who have graciously given this gift of life and possess antigens different than the patient. So these are the two methods in which people are exposed to antigens that they do not possess. This doesn't happen very often. Only 3% of the population may have blood group antibodies against red cell antigens they do not possess. So how do we determine if blood group antibodies are present? What we do is we take 3 red cell samples of known antigenic makeup, these are reagent cells, and test it with the patient's serum or plasma. Agglutination or clumping is a positive reaction, which would then lead to additional testing to determine the specificity or identify the offending antibody. This is a very simplified explanation of the process and it's all you need to know for now. Once the antibody is identified, then we must find donor blood which lacks the antigen, because otherwise if we introduced or transfused antigen-positive blood, we're giving them about 150-200 mL of red cells that possess this antigen, which could lead to an acute hemolytic transfusion reaction. The cross-match is the final test for determining compatibility between a patient and a donor. And in essence, we have unknown with unknown, meaning we don't know if that serum has antibodies against this donor, and we don't know what antigens are present on the donor cells. The patient's serum or plasma is tested against a drop of donor cells in a specific sequence. So you can see going from left to right, we have patient serum, 2 drops, donor red cells, 1 drop, and we incubate. And then after incubation, there's a procedure where we wash and add a special reagent, and no agglutination is considered compatible and can be transfused to the patient as long as the antibody screen is negative. Agglutination is considered incompatible and cannot be transfused to the patient. Let's discuss solid phase testing a little bit more. So for red cell testing, the wells are coated with a known antibody. For serum testing, the wells are coated with known red blood cells, meaning we know the antigen's present on them. If the antigen is present on the red cell, it will attach to the antibody on the well, resulting in a mat of cells on the surface of the well. So look at the 4+ reaction. There's an entire coating of the well with red cells. And you can see how the different reactions are graded based on the amount of cells that are stuck to the well. On the right-hand side, you see a 0+. There are no antigens present to which this antibody is directed, so all of the cells slide to the middle. So this is what differentiates a 4+ from a negative reaction in the solid phase testing. The endpoint reaction can be read visually or by a machine. Gel testing, the gel may have known antigen or antibody. For unknown red cells, which are agglutinated, they cannot get through the gel. So they will form a solid line somewhere within the gel, the top or middle of the gel. The unagglutinated red cells because they're not agglutinated, they can easily slide through the gel. They don't get stuck like agglutinated cells do. In this example, anti-A causes agglutination of the unknown cells. So see that line about 1/4 of the way down in the gel versus the anti-B, because the patient does not have the B antigen, all the cells are able to slither down through the gel and they're unagglutinated. These reactions can be read visually or by machine. I'm going to give you just a very, very, very brief overview of blood components. So donor centers draw blood from volunteer donors and separate it safely into its 3 major components, because not all patients need all parts of the blood. Red blood cells, also known as packed red blood cells, platelets, plasma. This is stored frozen and referred to as fresh frozen plasma. Or we can create a 4th component by taking that fresh frozen plasma, thawing it at 4 degrees in the refrigerator, and an insoluble precipitate forms. We then spin that down and we harvest this precipitate and it has a specific clotting factor, factor 8, which is needed for hemophiliacs or massively bleeding patients. The use of blood components, red blood cells. If a patient is anemic, they have a low red cell count, they only need red cells. Transfusing whole blood may result in life-threatening hypervolemia, too much blood volume, and can lead to cardiac arrest. Platelets, patient with normal red blood cell counts, but they have thrombocytopenia, which is a low platelet count, only need the platelets. And there's many types of diseases that may cause a patient to become low in platelets. And usually chemotherapy is one of those situations in which we transfuse platelets on a regular basis. Cryoprecipitate, low fibrinogen, which is a clotting factor. And again, this would be for our hemophiliacs or patients who are massively bleeding or who have this a low fibrinogen. So they don't need the red cells, they don't need the plasma, they just need this factor. During storage, clotting factors disappear and platelets die in whole blood. So even if a patient needed whole blood, it's better to transfuse with the different components. The picture on the left shows a unit of whole blood that's been allowed to settle. The top part is the plasma, and you can't see the platelet layer because it's very, very thin, but it's in between the red cell layer and the plasma. If you look on the right, the components that can be made from a single unit, we have the packed red blood cells, we have platelets, and we have plasma. And this last slide illustrates blood components and their use. So on the very far left, we have the red cells, and this is used to increase the amount of red cells either after a trauma, surgery, or treating severe anemia. These red cells are good for 42 days in the refrigerator and 10 years if we freeze it. And we only freeze very, very, very rare blood types. Fresh frozen plasma is used to correct a deficiency in coagulation factors or to treat shock due to plasma loss from burns or massive bleeding. In the refrigerator, it's good for 1 year. Concentrated platelets is used to treat or prevent bleeding due to very low platelet levels or to correct functional platelet problems. And I apologize for the spelling errors here, but this is not my slide, and unfortunately it's not able to correct it. These are good for only 5 days at room temperature. A platelet generally lives about 10 days, 7 to 10 days, and when we draw that patient, we have some platelets that are fixing to die and some platelets that have just been born. So just to be on the safe side that we give the maximal effectiveness of platelets, they only have a 5-day shelf life. And fibrinogen is used to treat fibrinogen deficiencies, and it is good for 1 year in the freezer. In summary, immunohematology is a fascinating area of laboratory medicine and my favorite. We test for the presence or absence of antibodies and antigens in a patient sample. In every test system, there will be a known antigen or antibody and an unknown antigen or antibody. And a positive result is heme agglutination, agglutination of red cells. The most common tests that are performed are ABO-D typing, antibody detection, and cross-match. There are 3 primary methodologies used to detect these reactions. They're the tube system, solid phase, and gel. Whole blood is made into components, red blood cells, platelets, fresh frozen plasma, and cryoprecipitate. The component given to a patient is based on their clinical condition and their need.